Dr. Keefer, and welcome to the GI Health Summit. Thank you so much for being here. I'm so excited to talk to you.
Yeah, thank you for having me. Me too. I'm excited.
What's really neat is that when I interview these experts for the summit, they often refer me to other experts. And when I was interviewing Dr. Lynn Chang from UCLA, she said that you must talk to Dr. LaurieKeefer, who is a psychogastroenterologist. And I said, sure, but what is a psychogastroenterologist? I have never heard of that field. What is it that you do?
So psychogastroenterology is sort of a newer term. We also sometimes interchangeably use it with gastropsych, but really meaning that we're applying psychological and behavioral principles to the study and clinical practice of digestive health. So obviously the brain and the gut are intertwined, and by sort of bringing in the psychological piece of the brain as well as the gut piece of the brain, we're able to help patients and advance the field.
Oh, you say that the brain and the gut are intertwined, and I've read books like Dr. Emin Myron's book, The Gut-Brain Connection, but there are some medical doctors that still don't believe that. And what if you're the person with IBS that goes to that GI doctor? How would anyone ever find their way to someone like you?
So we really are trying to increase our outreach to let patients know that there are people who are trained in evidence-based gastropsych. We have a lot of really effective interventions for patients, and they shouldn't feel that that if their doctor does refer them for such a treatment, I think there's a stigma attached sometimes, like, what, I have IBS. I came to see a physician. Why are you sending me to a psychologist? Why are you sending me to a mental health provider? And I want to reassure people that in gastropsych and psychogastro, like, we are here to treat your GI disorder. We happen to use behavioral techniques, but our focus is on your symptoms. And so by teaching the doctors to explain that better, I think we're much more likely to see the uptake. A lot of IBS patients have been told by their doctors that it's psychological, but they're not necessarily referred to the right type of provider.
Yeah, so that's just so great just to let people know that such providers exist. How many of them are you right now?
So we have a group, a membership through the Rome Foundation, and right now there's about 210 people who are part of that group. There are probably plenty of people out there practicing in this area that we would love to, take under our wing, but it's still a pretty new field, and there's not a lot of people who are trained specifically in gut psychology, gut health.
That's so interesting. How would you get into something like that?
So, it's really funny. I have been doing this for over 20 years now. I trained, my PhD was in clinical psychology at the University of Albany, and my mentor, Ed Blanchard, at the time was really the main person studying something called behavioral medicine more broadly. And behavioral medicine is basically the application of behavioral principles to health conditions. And so when I started grad school, we always had to do this project when we started, and usually your mentor assigned it to you. So he assigned it to me, and he said, Laurie, I want you to do this study where you teach people with IBS how to meditate. And I was like, what is IBS? And then I was like, how am I going to tell my parents I'm studying poop? I went to school to be a psychologist. But like anything else, the more I studied it, the more I fell in love with the brain-gut connection and realized the fact that you can actually change GI symptoms by targeting the brain. And I was hooked after that. And I've been in gastro my whole career, basically.
That's just very fascinating, and it can bring people a lot of hope knowing that your brain can affect your gut. So maybe talk a little bit,
Yeah.
How does the brain affect the gut? Does it affect everybody's gut or just people with symptoms?
Well, so that's a great question. I actually get that a lot. I mean, I think, first of all, the brain and the gut really cannot be separated, right? So the brain is always affecting the gut. I tell people all the time, the brain is central to all of our life experiences, our heart, our lungs, our GI tract. The gut happens to be an organ system that interacts more with the environment than a lot of other organ systems, other than maybe like the skin. And so because of that, the brain can really get dysregulated relatively easily. And by dysregulated, meaning the brain has its own nervous system, as you know, and so does the gut. And so the gut's nervous system, the enteric nervous system, communicates up to the brain and says, I'm hungry, I'm full, I need to go to the bathroom, don't eat that, that's bad for you. But the brain can also, brain can also communicate down to the gut that there's a stressor, don't digest, route all your blood flow out to your other extremities so that you can fight or flight. No reason to eat now. So depending on the scenario and depending on how much of a gut sensitive person somebody is, the brain can have more or less influence. Some people are like, I'm a gut responder, right? What I eat matters, my diet matters. That's what drives my symptoms. Other people are like, it's my stress, it's my brain, it's my fear, my anxiety. Other people are somewhere in between. And that's sort of how we think about that brain-gut connection, but not to disentangle them, but to really look at the role each thing plays in that bidirectional relationship.
Can stress just play a role just about in any disease that somebody gets?
Of course. I mean, I tell my patients all the time, it's not that stress causes disease. Stress doesn't help anything get better. And having symptoms that are, especially in IBS, where people are having urgent diarrhea, unpredictable, that's stressful. That's the stressor. A lot of people handle stress really well, but throw in some unpredictable GI symptoms, bowel symptoms. They sit down at the table to eat something and their stomach starts to hurt just because they've paired the stress of eating with food. So I really think of stress as that added, as an added layer that we have to be more proactive about when you have a GI condition.
It seems as people have heart disease and they have diabetes and they're very comfortable, or even cancer, talking about it. But when it comes to the bowel, it's like, why is it so embarrassing to people to discuss this? Some even won't get medical attention because they're even embarrassed to tell their doctor.
Yeah. Yeah. I mean, I think that there has always been such a stigma around bowels. And, people see them as gross and disgusting. And a lot of my patients say they just feel so gross by talking about it. They feel like they're not clean, or they're sluggish, they're self-conscious. And then I think on top of that, people have historically called things like IBS psychological disorders. So you have this double stigma of having GI problems, poop problems, and then you have other problems of people saying, oh, it's what you eat. You don't eat healthy, or you're too stressed, just relax. So the double stigma, I think, really impacts people seeking healthcare.
That's one of the main reasons I'm doing this summit, to let people know it's okay to talk poop.
Yes, absolutely.
Yeah, it's actually kind of fun. I mean, well, not having IBS. But it's so we need to make it so that it's not so stigmatized, because everybody does poop, by the way.
That's 100% right. And actually, if you look at cats, a lot of them will have IBS-like symptoms. Dogs, it's not just a people thing, right? These conditions happen for a lot of reasons, including this brain-gut dysregulation.
Right. So when doctors refer to something as functional GI disease, what does that word functional mean?
Yeah, that's a great question. So we're really actually trying to get away from the term functional. By function, we really mean that there's a problem with the way the digestive tract functions, but there's no real structural or inflammatory marker that can explain that functional difference, right? So unlike ulcerative colitis, where you might say you have little ulcers lining your colon, we talk about in IBS, for example, there aren't those ulcers, but the symptoms are the same. So why is that? And so what we kind of refer to is you have this functional disorder. The problem is as to your point earlier about the stigma, is that functional became synonymous within your head. And that was never the intention. The intention was a descriptor, right? You're having trouble with the function. We don't know why yet. I give patients examples all the time about ulcers, right? We used to think those were caused by stress. I remember my grandpa had an ulcer and we said, oh, he was too busy working at his gas station and he needed to rest. And then, 20 years later, there's H. pylori causing the ulcer, and nobody would call that stress related anymore, really. So functional really just means we don't have a clear explanation, or we don't have a test to show what's actually happening in the gut, not that it's not a real condition.
Well, that's why it might be so beneficial for somebody to see a professional such as yourself to assure them, yes, it's in your head, but it's not in your head.
That's right. Exactly.
Yeah, that's terrific. How has neuroimaging helped, and how does brain imaging differ in people with GI disorders?
That's a great question. So neuroimaging really has been a key, has played a key role in the field of psychogastro, because, while we as psychologists might have known these things just intuitively, like, of course, the brain is involved in how fast your gut moves or how slow your gut moves, neuroimaging has been able to show pictures that the brains of people who have these disorders are different than the brains of people who don't. And one of the, there's a couple, and probably your guest, Dr. Mayer, when he comes on eventually, we can tell you more in more detail. But, we know that there are people with IBS, for example, who have, are much more hypervigilant to sensations in their environment, right? They're more sensitive, just at rest, their resting state. So they are taking in input from the environment that is going to affect their GI tract much more often. It's harder for them to ignore things, to ignore sensations, and then that contributes to the added stress and symptoms. We also know that patients with chronic pain, not just chronic abdominal pain, but chronic, back pain and that type of thing, often have parts of their emotional response system, their limbic system, that really prevents them from mounting the full response to the pain. They're sort of handicapped almost, hand behind their back, coping with the pain because their bodies just can't mount that response. And by showing all of that via neuroimaging, particularly in irritable bowel syndrome, where it's been done most often, we've been able to say, again, it's in your brain, but there's actually something going on here. And it also set us up for being able to say, well, you know what? The brain has neuroplasticity. The brain grows. The nerves and the cells turn over in the brain. So if we can work on your resting state, we can keep you from taking in too much stimuli. We can increase your brain's ability to manage pain when it comes in. Now we have justification for some of these behavioral therapies.
It's interesting. My grandfather was a physician, and he graduated medical school in the early 1920s, and he was known as a GP, or a general practitioner. And now there's so many specialties and subspecialties in medicine. It's almost like the doctors forget that the parts of the body actually talk to each other.
100%. That's exactly right. And that's what happens in IBS, right? So you have the parts of the body that are supposed to be talking to each other become dysregulated. They're not communicating properly, and we have to sort of rein that back in. Usually it's after some event, right? It's not like you're just born with dysregulated GI tract. It's usually after an injury to the colon, and food poisoning, an infection, a trouble, a chronic stressor, a long time not sleeping. Something sets off that dysregulation. And then something also, and I always tell my patients this, the things that start off your problem aren't always the same things that keep your problem going. And so there are other factors that kind of keep that infection or injury or, trigger of IBS going in your current environment.
I often hear GI doctors talk about the Rome criterion. What is that? And why is that important?
So it's really important. So the Rome criteria is really the only criteria that we use these days to define these disorders, these functional GI disorders, now known as disorders of gut-brain interaction. And prior to that, nobody knew what these syndromes were. It was people were told they were sort of, hysterical, they were crazy. There was no real way to understand them. And by developing criteria and thresholds, we've been able to research much more right now, because you can sign up for a study if we actually know what you have and what's going to change as a result of that. We can develop treatments, right? So the idea that IBS is a pain disorder that's associated with altered bowel habits, knowing that, validating that, allows us to be able to generate new treatments, new therapeutics, new diets, new behavioral interventions. So the more we classify patients, the more legitimate the disorders become, the more communication can occur between providers, right? So a doctor can tell me your patient has IBS, and I say, okay, I know what that is, right? I know that that's not just my patient has abdominal pain. I know that that's a different disorder. That's centrally mediated abdominal pain. If they say IBS, then I know that that pain is associated with bowel movements, and that changes my treatment. And I think that has been a huge component of Rome. It's also really destigmatize the concept of functional, because Crohn's disease has criteria, ulcerative colitis has criteria, celiac disease has criteria. Why not have these disorders have criteria? They're just as debilitating.
Yeah, absolutely. Would somebody have to be referred by a GI doctor to see a psychogastroenterologist, or is it something they could just do on their own?
So we really try, you can always refer on your own, but we really try hard enough, or we really try hard to collaborate with the GI doctors. And so we're pretty insistent that you have had your diagnosis, that you have a treatment plan that your physician is comfortable with, right? Because, let's say somebody thought they had IBS, but really they had colon cancer, right? And the psychologist thinks they have IBS, and so they're like, oh, let's do gut-directed hypnotherapy for that problem. And their pain decreases. And so then the patient doesn't realize that actually they still have colon cancer, right? So we really want to be careful about that. And so that's where, the collaboration is always best to be considered GI psych. Can you see a therapist? Of course, your IBS might get better if you see a therapist. Your anxiety might improve. But in terms of the GI component, we really like that collaboration.
Yeah, makes sense. It's just sometimes when you see a psychologist, your insurance doesn't pay for it like what they
Right.
would pay for the GI doctor.
Yeah, right, exactly. And, we're lucky. I mean, I practice in an academic medical center where I can bill patients for their medical condition, and I don't have to assign them a random psych diagnosis just to get covered, right? So I can bill a patient for their Crohn's disease or their IBS. And insurance covers that pretty similarly to if they came in to see my GI colleague next door. But you're right. That's really a hard part of that is the reimbursement of mental health treatment.
Oh, that's good to know that you can do that. Can you talk a little bit about the biopsychosocial model of functional digestive diseases like IBS?
Yeah, absolutely. So really the biopsychosocial model is the framework of IBS and really should be the framework of all health problems, in my opinion. It's been around since the 70s. And the idea is that you cannot disentangle biological from psychological and from social factors, right? So in IBS, as an example, on the biological level, we have genetics, right? A lot of people, as parents, had IBS. We have, inflammation or injury or something that sort of triggers the symptoms. We can have early environment, right, that you're exposed to that has nothing to do with sort of later on. All those are biological factors, sensitivity to medications, different types of genetic factors. So then you're born with those are sort of set in stone, or you can have them happen to you later on in life. But those biological factors intersect with psychological factors, meaning how did you learn to express pain when you were a child? Right? Did somebody reinforce your pain? Did somebody tell you have no empathy for you? How do you handle depression? Are you anxious? What kinds of coping strategies do you use? Are they effective? Are they not? Do they apply in this situation? Did you have child abuse? Did you experience child abuse early on in your life, and that's affecting you? And then finally, socially, what culture are you from? What socioeconomic status are you from? Are you under financial stress? Do you have access to healthcare? All of those things lead to the way in which you experience your symptoms, whether that is how you use healthcare utilization, whether it's symptom severity, whether you even seek care or not, all of those, how much care costs you, all of those things contribute. And it's really important for physicians to know each of those factors, right? It's not just this, I have 12 bowel movements a day, and so therefore I must be in a flare, right? It's, I have 12 bowel movements a day, but I'm also really stressed out, and I haven't taken my medication for 6 months because I ran out of insurance because I lost my job. But my childhood experience of being abused, prevents me from actually advocating for myself or asking authorities for help. Right. So it's never just this one thing. And I think we can be so much better at helping patients if we can look at them as holistic as possible.
Yeah, I love that. Thank you. How do psychological factors influence gut motility and even the pain that patients experience?
Yeah, that's a great question. So when I think about motility, I think about fight or flight primarily. So I think about the fact that when we are when the autonomic nervous system sympathetic nervous system kicks on in response to a threat, saber-toothed tiger coming down the mountain, ready to eat you, nobody stops to have a hamburger, right? Nobody stops and says, hold on, tiger, I just need to run to the bathroom first. So all of that shuts down and allows you to focus on that stressor, on that fight. And so motility slows down in the middle of that stressor. And then after the stressor is over, motility can pick up again. You turn on the switch of your GI tract. And for some people, that results in diarrhea. For some people, they're like, how do I know that tiger's not just hiding behind the corner? Did he really go away? I'm going to hold on to this stress just a little bit longer. I'm not going to let go of it. And so I really talk to patients a lot about making sure that even if obviously there are no more saber-toothed tigers out there, but there's COVID, there's all sorts of stressors that we're facing, trying to make sure that even if we're facing those stressors, we don't let them affect our gut so that our motility, so we continue to rest and digest, even if cognitively we're stressed out. So that's how I sort of think about it from a motility perspective, is sympathetic nervous system, parasympathetic nervous system. And you get breathing exercises. There's all sorts of ways to do that to affect your motility. Motility in the esophagus, for example, after eating, we can have people do breathing exercises that keeps the food from coming back up from ruminating. We can also increase gastric accommodation, how much food can fit into the stomach through a breathing activity. That's all sympathetic, parasympathetic nervous system and mechanics. When you talk about pain, the other big symptom, right? I think much more of brain level issues. And if you remember, we talked about how the brain can be, emotional response centers are sometimes not mounting a correct response. So in those sensations, it's the cognitive processes, it's the fear, it's the, oh no, what's going to happen to me? It's the amplifying of, I have pain, what if it's colon cancer? It's the, I just ate that, now I'm going to throw up. What am I going to do? Everyone's going to see me. It's the, I'm bloated, that lady down there just asked me if I was pregnant, right? Those thoughts and processes all contribute to pain being experienced at a much higher level than it could be. And that's where some of our cognitive approaches come in more so.
If stress can affect gut motility, so many people say they're stress eaters. It almost seems like people with GI problems would be better off not eating when they're stressed.
Yeah. Yeah. And a lot of times we say it's not even what you eat, it's the fact that you did eat, right? And at a time of of stress, for sure.
You mentioned diaphragmatic breathing. How physiologically can that behavioral technique help with things like IBS?
So diaphragmatic breathing is just one of my favorite tools. It's so simple. People don't do it often enough. And in the GI tract, it really has a huge impact. And when I teach doctors, I'm always pushing them to teach it to their patients in clinic because it has so many indications. So one is the parasympathetic nervous system, as I was saying. So something as simple as inhaling 4 seconds oxygen, 6 seconds out carbon dioxide can tell your brain that there is no emergency and that the parasympathetic nervous system can kick back on. Very simple technique, slows things down, right? You're in Target, you have to go to the bathroom, it's on the other side of the store. You don't know how you're going to get there, you start panicking, tense, get ready to run. Or you take a couple deep breaths, you slow down your motility and walk there and make it, right? So something as simple as that can be done in the moment. Two is we know that people with chronic conditions, people with chronic pain, often do not use the bottom half of their lungs, right? In general. And so they're breathing more, they're swallowing more air, which is not good for the gut either. They are having a harder time. They're wasting energy basically on breathing, and it's harder and harder for them as they're symptomatic to kind of recover because their breath is inefficient. And so even practicing diaphragmatic breathing is really helpful for that. And then we use it for a lot of other things, as I mentioned, with the esophagus, allowing the reflux to sort of stay where it's supposed to and not up in the throat, or helping food move down in your stomach.
Is the different variations of IBS, is the way the patient's response to these type of treatments different? I guess what I mean is, like, if you have IBS with constipation, you can still leave your house because you'll stay constipated. But if you have the diarrhea, you're thinking, oh my God, I can't go to this party because what if it seems like that would be in some ways more stressful because you worry about having an accident and not being able to find a bathroom.
Yeah. It's funny too, because patients always, they're always like, the grass is always greener on the other side of the symptom profile, right? So the diarrhea people are absolutely, they're like, at least if I was constipated, I wouldn't have to, stink up somebody's bathroom at a dinner party, right? But the constipated patients also feel like they're uncomfortable, they're in pain, they're sluggish, they're bloated, they pass gas, they look pregnant, they can be equally distressed. And they're like, if I just could go to the bathroom more, I would be okay. So it's really, the beauty of these brain gut treatments is that it doesn't matter whether you diarrhea or constipation or you alternate, right? They're agnostic. Unlike a lot of our medical treatments are very symptom specific, right? Like, you're constipated, you take a laxative. If you have diarrhea, you take an anti-diarrheal. For us as GI Psych, it doesn't matter because we're treating this brain gut dysregulation, not the underlying symptom. And so if you're constipated, you could amplify those symptoms in your brain just as well as a diarrhea patient could. Diaphragmatic breathing could help in a constipation situation where you're anticipating pain on the toilet, right? I haven't gone in 4 days. I'm going to push it out and it's going to hurt. So I'm going to do my breathing there. So there's a lot of these techniques. What I love about them is a lot of these techniques doesn't really matter what symptoms you have. They benefit you in different ways.
So maybe talk about some of the psychological techniques you use to help people with the brain gut dysregulation, and maybe even some of the research that's behind them.
Yep. So we have a few classes of what we call evidence-based brain gut psychotherapies. So they are psychotherapies that have been adapted from effective psychotherapies for other problems, depression and anxiety, but they've been they're targeted at these exact sort of mechanisms that we've been talking around, right? The sensitivity, the motor discussion, the overactive emotional response network. So depending on sort of what combination of those causes you have for your brain gut dysregulation, we might use any number of interventions. So one of the most robust studied and randomized controlled trials, replicated in a bunch of different formats against a bunch of different control conditions, is cognitive behavior therapy. But it's not cognitive behavior therapy like you hear about in the media, where, you know, you're depressed and you learn how to think more positively and more accurately. It's cognitive behavior therapy for IBS, for heartburn. And it's really focused on exactly what you're just talking about. How do I get out of the house and not catastrophize the fact that I'm going to go out and I'm going to sit in the bathroom while on a date, right? Or I pass gas in public on the bus. Those are the cognitive behavioral things that we target in CBT for GI conditions. We're not talking about other types of issues. We're talking about fear of symptoms, that type of thing. And we're reducing avoidance is the other thing. So when people have these symptoms, they often avoid a lot of things in their lives, which further isolate them, further suggest to them that they don't have control over the condition, and further lead to more and more distress. It becomes a very vicious cycle. And so cognitive behavior therapy is really good at those things. It's like, you know, I work in New York City. So for us, it's like, you're afraid to ride the subway, so you're no longer going out with your friends if it's not within walking distance, because you're afraid you're going to have to go to the bathroom while you're sitting on the subway. Okay, so let's go one stop. Let's try that out. Let's see how you do. What do you have to tell yourself to get through that one stop? What happens if you have an accident on the subway? You know, what would you actually do?
Yeah, that's what I want to know, because I was thinking that was what I was thinking in my brain. Like, how do you, let's say it really does happen. Somebody farts in church, or, you know,
Yeah.
do you teach them how to get over the embarrassment? Like,
Yeah, that's exactly right. So we say, all right, you know, I didn't want that to happen, but it did. Can I cope with it? Right? Was I embarrassed? Of course. But, you know, what am I going to do? Call 911, you know, run out in the street, never go back to church again. You know, there are so many things that I think people magnify in their heads. You know, another common example is, what would you do if the guy next to you farted? Right?
probably laugh. Maybe I'd laugh.
Maybe laugh, maybe share, like pretend you don't know, depending on who the person is, right? What would you do if somebody, you know, had a bowel accident in public at your, you know, local store? Would you help them? Would you run away? Would you stop and point at them? You know, there's a lot of ways. And some people say, yeah, I would. And
Yeah.
other people are like, oh, no, I wouldn't. And so we leverage the way people would handle things happening to others as a way of sort of taking away some of that shame and stigma of having the condition, and really start to shift their thoughts around it. And I've had plenty of patients whose biggest fear in life is having a bowel accident in public. And then after it happens and they realize that nobody really even noticed, and that they just turned around, went home, changed, took a shower, and went on with their day and never told anyone about it, it's not that big of a fear anymore. They've handled it. They've coped with it. So CBT can be really helpful, particularly for patients who have this type of problem, right? The ones that are overthinking their symptoms, the worst case scenario. Are they going to get stuck, you know, driving over the bridge and have to go to the bathroom? What if they have to go stop for the bathroom and they're in an Uber? You know, all those thoughts and processes that people use to justify avoiding, we're targeting with that cognitive behavior therapy. Another class of treatment that's also very helpful is gut-directed hypnotherapy. So, you know, that sounds kind of silly, right? Hypnosis, like, you know, you're thinking of Cluck Like a Chicken on the stages of Vegas, but hypnosis is actually a very powerful tool for pain management. Because it helps mount, again, going back to the pathophysiology of this, it helps you mount the response that you need to turn off those pain signals, right? And so under hypnosis, we're able to suggest to patients that the pain they're feeling is not as severe, much more comfortable. They have control over it. You know, hypnosis is a relaxed state, But in addition to relaxation, you also infuse it with these suggestions that if I were just to say right now to you, you'd think I was quacky. But if you were in a hypnotic state, your brain would kind of believe it. And so we use that a lot to use the subconscious for patients who tend to have maybe less of those catastrophic cognitions and those CBT avoidance behaviors, but people who are very sensitive to, what they ate. A lot of times we'll do hypnosis around people who have chronic nausea, right? Or other really unpleasant sensations that they're not necessarily like catastrophizing, but they're really uncomfortable. Hypnosis can be a really useful strategy. And then we have there's newer stuff coming out. Mindfulness-based stress reduction has some efficacy, at least in IBS, and to some extent in inflammatory bowel diseases. Some of the third wave behavior therapies, acceptance and commitment therapy, where rather than trying to control everything about your life, you sort of release control and let things happen, and accept that you might have diarrhea and abdominal pain sometimes, instead of trying to avoid it. So we have a lot of behavioral therapies that have been customized and scientifically studied in randomized controlled trials, just like drug trials, that work on these symptoms.
So if I were to come to you as a patient, and by the way, can people see you remotely or do they have to come to your office?
So I do a lot of telemedicine. There's, tons of restrictions around licensure and, reimbursement and all of that around telemedicine that you don't necessarily get in person. But yes, and we have, a lot of people who have undergone training in some of these therapies. For example, nurse practitioners, a lot of them have been trained in gut-directed hypnosis. So you might not be able to find a therapist that does it, but you might be able to find an NP or a physician who does that particular type of therapy as well. You might also find a CBT therapist in your community who doesn't necessarily know GI, but could pick up some of our research studies and learn about how we adapted CBT to the GI condition. And so I think for patients, if you know what the interventions are, if you know what's evidence-based, you can try to make it work even if you don't have a GI psychologist in your community.
That's just so cool that you're explaining what all these modalities are. Do you personally administer the CBT and the hypnotherapy when somebody comes to see you?
Yep, I do a lot of both. Right now, my practice is focused exclusively on Crohn's and ulcerative colitis. But I've had tons of IBS, I've had an IBS practice, I've had an esophageal practice, I've had a reflux practice, pretty much all sorts of things that
you're just hitting the whole track from mouth to anus.
Burping, chronic nausea, chronic abdominal pain, the whole range of things that can go wrong with your digestive tract. But yeah, so, all those modalities apply to Crohn's and colitis just as much as they apply to IBS, because again, it doesn't matter to me whether you have an ulcer or not. Explaining your symptoms, the brain is still involved, right? The brain is still telling you that something is uncomfortable, even if we know what that is. Oh, it's your ulcer, but we're treating it. So you don't have to, it's not a threat, we're treating it, right? So you still can have dysregulation because you had a history of being really sick, and now your brain is scanning the environment for cues that you're going to be really sick again. And so for me, these therapies work across the gamut for patients.
A lot of times people choose their careers based on something that happened to them. Have you ever suffered with any of these GI disorders?
I haven't, other than hyperemesis when I was pregnant with my son. But I certainly have family members that have, experiences with these. There's such common disorders in the population as well. I mean, it's pretty funny when I take on new students, a lot of times they go and they start telling their friends and family what they're studying, and they find out that so many of their friends and family have these conditions as well.
That's good. Well, thank you for being so empathetic to people that have it. So,
Yeah.
all these different modalities like meditation, mindfulness, hypnotherapy, CBT, how does one decide what to try, or does the doctor just try them all?
Yeah. So usually, I mean, this is why I think it really is important that people don't just, sign up for a type of intervention, because I think it really helps to have had an evaluation by an expert, even if you end up doing, there's a lot of opportunities now to do digital or home-based or book-based interventions, but an assessment can be really, really helpful because I may not recommend hypnosis for somebody, even though on paper it sounds good. Or my physician colleague might say, oh, you should do hypnosis. But then I find out the patient has an extensive trauma history, or they don't like the loss of control, or there's a religious belief that keeps them from doing it, right? Other patients, cognitively, they're not willing to think about their thoughts as open for debate, right? So you ask them what a thought is, and they're just not that type of a thinker, right? They don't think like, oh, that was a thought, let me switch it. They're much more likely to do something like a hypno. So I think you do need an evaluation by somebody who knows what they're doing, and then you can sort of play around with how you get the intervention delivered, because otherwise, I feel bad for patients who spend a lot of money on treatments that might have efficacy but aren't customized to their personal problem.
And that's why I love this idea of a whole person approach. It's kind of like what they do at UCLA, where like you literally get a team of people, nurse practitioner, dietitian,
Yeah.
GI doctor, psychologist. And that, I mean, you'd have to succeed with that many people on your
Yeah,
team, I would think.
and we're collaborating too, like the dietitian, patients avoid food and the psychologist can work with the dietitian. All right, this week, the person's going to start to introduce raw vegetables again that they've been avoiding. So the psychologist is going to teach them diaphragmatic breathing, and the dietitian is going to tell them how to cook it, in a way that, or I guess I use raw vegetables, or how to prepare it in a way that'll be, healthier for them or more comfortable for them, or maybe they just do one food at a time. I mean, your expertise is probably much more in that line of thinking, but we're really trying to help people adjust their behavior. So many of these conditions can be treated with lifestyle.
Has acupuncture ever been helpful with this problem?
Yeah, so there have been some studies on acupuncture for both IBS as well as for, I think, some of the upper GI conditions. Absolutely, I think for pain in particular, it can be really helpful. And I refer patients a lot actually for acupuncture if it seems like that's something that kind of would, they need that added physical manipulation for their care. So yeah, from a complementary alternative medicine perspective, acupuncture definitely is one of those things for which there is efficacy. Peppermint oil is another one that has growing evidence behind it for IBS.
Like if somebody has diarrhea or constipation, you generally don't know unless they tell you, or maybe they were to have an accident or something. But one of the symptoms that I hear about from so many people, and it's particularly disturbing, men don't like it, but even worse in women, is not the bloating, but the distension.
Yes.
You can, and especially like if a female is maybe more slender, like you say, they can look like they're 9 months pregnant, even if they're 60 or 70 years old. Do you have any techniques to deal with not so much maybe the bloating, but the embarrassment about the bloating when you go outside?
Yeah. So that's a great question, because that's the quality of life impairment is often because of the distension, even more so than the sensation, right? It's that people can tell and people can notice. But that's again where the cognitive part can be really helpful, right? It's like really sort of shifting over to, how much are people really paying attention to you? In this day and age, people tend to be pretty focused on themselves and their phones and other things, and so we'll often joke, is someone really shining that spotlight on your abdomen right now? You're feeling it, you're self-conscious about it, but maybe your avoidance is not necessary. We also talk about living a meaningful life, and getting past things that keep you from doing that, right? Like if you need to, go out and wear your swimsuit because you want to go swimming and you're bloated, you're not a swimsuit model. Like you're there to swim. Let's use our bodies for something that is, consistent with our values. Yeah. And I think, again, most of us aren't saying, oh my gosh, you look like you're pregnant, right? Like, I think we've tried at least to get people in society not to comment on those things.
You should never say that, because sometimes they're
You
not, it's
never
not,
know, right?
and they might not have
People-
IBS. They might just have gained some weight. And so I learned a long time ago, never ask a woman or anybody, are you pregnant?
Yeah, right. Yep, that's exactly right. Yeah. So, but there are a lot of cognitive strategies that can help people become a little less self-conscious about that and really choose to live the life that they want, and not worry so much about their appearance.
I wish they would have got like a magic pin.
Right? Yep. When I do hypnosis for bloating and for distension, I often use a balloon metaphor where it's sort of deflating or distributing in some way.
That's cool. I imagine the people that are attracted to signing up to view this summit probably have some history of GI diseases, but it almost seems like we need another summit for everybody else to understand this. Because when you had said, like, if somebody had a bowel accident in front of you, what would you do? And I started thinking, well, I used to be an activity director at a retirement home, and that happened all the time.
Okay,
but
yeah.
I've never seen it really on the subway, and I would never shame the person, and I wouldn't laugh. I mean, I might laugh. Farting for some reason makes me laugh. I don't know why. But I don't think people are really educated with the disease and how to help a loved one with this disease, because it's personally not really talked about.
Yeah, right. I mean, building empathy is such a huge part. I see a lot of caregivers, spouses, parents trying to help them kind of understand the burden. And, it's a concealable disease for a lot of people. So you look fine, but I don't understand. You look great. How can you be so burdened by this? Or the idea of chronicity, right? Which is, why is it some days you're fine and other days you're not? I'll hear people say, well, why is it you can go out to out to dinner with your friends, but then you cancel the soccer game that we were going to go to? Well, turns out that a bathroom is available at one and not the other, right? It's not necessarily like, oh, you just care more about, going out to dinner than you do your kid's soccer game. It's the circumstances, and people don't always think through that and need a little empathy around these issues.
That's great. What is resiliency? How is it predictive of disease activity? And why is it so important in patients with inflammatory bowel disease?
Yeah. So, resiliency, everyone has resilience. People in general are resilient. Some people have more than others. Some people need to learn resilience, and it can be taught. But resilience is basically the ability to bounce back after life brings you lemons, right? And not just survive, but thrive, right? So we say you get a GI diagnosis, you get something, very serious, like Crohn's disease, you get something debilitating like irritable bowel syndrome. How are you going to take that diagnosis, accept it, and figure out how you're going to bounce back and not let it define you? And what we know is that patients who have high resilience tend to adjust to their symptoms. They they're willing to put in the lifestyle and self-management work that's required to maintain these conditions. And instead of focusing on why did this happen to me and who's going to fix this, right? They take ownership and they say, I have it. It's unfortunate. Bad things happen to good people sometimes, but how am I going to live my life the way I want to, despite having this problem? And what we found in IBD, because this is my research area, we found in IBD that this can really predict quality of life. It can predict whether or not people continue to have disease flare-ups or not, and that we can actually modify resilience through a variety of these same techniques that I was just talking about, teaching people how to cope a little bit better or how to bounce back. In IBS, Lynn Chang has done a lot of the resilience work there, and she has also shown that sometimes people with IBS have had maybe resilience that's similar to the population, but if they have a history of trauma and low resilience, that they're much more likely to go on to develop some of these health issues.
It seems like resiliency would be a good training for almost everybody, even without a disease.
Absolutely. And it's really about confidence that no matter what comes your way, you will deal with it. You'll bounce back, and that bad things happen, and we never know when that's going to be. And but if you can trust that you have this social support and that you've maintained some optimism, that you can actually bounce back from pretty much anything.
I can't help wondering if other people are also going to be new to this term psychogastroenterology. Are there other fields like psychocardiology, psychonephrology?
There are. So psycho-oncology was probably the first, sort of formative group, right? So end of life, cancer, coping, traumatic, stress associated with cancer. So we kind of modeled psychogastro after psycho-onco because that became its own sort of field. But there are absolutely, I have colleagues who are cardiology psychologists, people who psychodermatology, right? There's a lot of skin conditions that are really upsetting to people for whom psych has. And then if you think about the field of neurogastro, which is where we kind of started too, right? Which is that brain imaging, what's the nervous system of the gut, how do things move on? Psychogastro is very complementary to neurogastro. So it's funny because I sometimes get some flack for calling it psychogastro because it's such a mouthful. But if we want, because we call a lot of other things the study of, right, that, psychogastro seems to fit with that. But for short, we say gastropsych because, the word psycho doesn't always play out well in the general population.
You're taking the psycho out of psychogastroenterology.
Exactly.
That's funny. So, Dr. Keefer, are there certain skills or skill sets that can help people cope with either acute or chronic GI symptoms?
So, I think going back again to anything that can deactivate your nervous system, breathing in particular, I think can be really helpful. I think that's probably the most portable and effective acute symptom tool for anything, right? And then I think for longer term, really for me, I think the main skill that people can learn is confidence that no matter what happens, they will deal with it, right? We spend a lot of time worrying about what we would do if the worst case scenario happened. And most of the time, even if the worst case scenario happened, we usually know what to do. And all the time we spent worrying about it didn't really make it go any better. It was still the worst case scenario.
Yeah.
Right. And so I often tell people, really being in the moment and not overestimating the likelihood of something happening is going to be.
And I imagine that people do that in other areas, not just in their IBS. So learning how not to catastrophize, I think, would be a great tool for anyone to learn.
Yeah, that's right. Yeah. And I often have my patients pick like a mantra that they can use to capture that, like, bring it on. So what? Big deal. Who cares? As ways to sort of dampen the anxiety and fear, which, or is this worth symptoms? Is it worth upsetting my stomach to worry about this problem? Is it really worth making my IBS worse by worrying about what I'm going to eat for Thanksgiving dinner? Probably not, right?
It's just so interesting how stress really does. It really can affect your gut. I know for me, I wish these resources were available 6 years ago when I had it. But I was very in tune with when stress, and I think anything we can learn to help mitigate our stress is only going to improve our gut.
Absolutely. And you can apply that too. Some people are gut responders. Other people get headaches. Other people get hypertension. Like, we all have sort of an organ system in our body that is most impacted by our stressors. And that's when we have to be, that's a sign. It's like something's wrong. My gut feeling is that something's not going right now. And I need to do something about it.
And we are living in a very stressful world right now.
Yeah.
Surprised there's not more problems.
Yeah, For sure. And I mean, even people without these conditions, without these actual Rome criteria disorders, are struggling with GI symptoms right now.
So what kind of hope can you give to people suffering with either acute or chronic GI symptoms? Is this something that can be overcome or at best just managed?
I think there's a subset of people who should be very optimistic that it can be overcome. I think there's a lot of factors that go into that, resilience being one of them, maybe getting care earlier on and not letting it debilitate you. I find it's much harder to treat somebody after they've tried every other thing under the sun, and at the last ditch effort is when they try the behavioral treatment. And I'm like, I could have helped you so much better long ago, before all these things had happened to you, right? You've accumulated all of these bad outcomes, and now we're going to have to just focus on managing. So I would say to people, don't be afraid to seek out these treatments early. They have very low harm rate, right? They're not going to hurt you. They can be done in conjunction with your medical treatment. They're not opposite or opposed. And if you do that, I have very strong optimism that you could actually recover. I think that there's probably a subset of people, though, who really need to go back into that acceptance and management, and how can I live a meaningful life despite this GI condition as well.
Well, that's one of the reasons I'm doing this summit, let people know all the options that are available that I didn't even know about.
Yeah. Yep. Exactly.
Yeah,
That was great.
That is so cool. Well, thank you so much for the work you're doing. And one last question, Dr. Keefer, what is the truth about GI health?
For me, I would say the truth is that we cannot separate out the brain and the gut. Those are bidirectional pathways, and we can't consider one without the other.
That's it. Can't have one without the other.
That's exactly right.
Well, this was just a wonderful interview. Thank you so much, Dr. Keefer.
My pleasure. Thanks for having me.